This is part 2 of a 4-part orientation intended for resident physicians rotating through the NICU at WVU Medicine Children's Hospital. This presentation will introduce tasks encountered during pre-rounding with a focus on normal and abnormal vital signs in the NICU. The topics covered in other presentations include an overview of general expectations and daily workflow in the NICU, interpretation of common laboratory tests performed in the NICU, and how to calculate fluids and nutrition for neonates. The content of this presentation has been modified for our NICU, but is based on a NICU boot camp created at Louisiana State University Health Science Center, New Orleans, Children's Hospital of New Orleans. Further details can be found at the following web address. The main point of pre-rounding is to prioritize patients' problems based on acuity and to gather the pertinent information needed to synthesize a plan of care for the day for each neonate. The components of pre-rounding include reviewing the notes and data, including vital signs, in the patient's electronic medical record, getting the numbers for fluid and nutrition intake, talking to the patient's bedside nurse, and examining your patient. The data gathered in pre-rounding is not gathered for the sake of gathering data. Rather, it is to be used to give an informed, complete clinical picture of the patient that can serve as the foundation of developing a plan of care for each individual neonate. In the coming slides, we will discuss where a patient's vital signs can be found. Following this, we will discuss what are normal and abnormal vital signs in the NICU and what abnormalities may mean. Ranges and trends for a patient's vital signs can be easily found on the Summary tab and Patient Dashboard Report. Ranges from the previous day, 7 a.m. to 7 a.m., the current day, 7 a.m. to the current time, and the most recent values are reported. Vital sign ranges over the past 24 hours can be reported on morning rounds. It is important to not only recognize abnormal single measurements, but also abnormal or worrisome trends that may warrant diagnostic evaluation and intervention. When discussing the vital signs on rounds, make sure to highlight abnormal values or worrisome trends as part of synthesis of your assessment for the patient. Vital sign trends over longer periods of time can be evaluated in the Synopsis tab. In this example, vital sign trends over the last 7 days are displayed. In the following slides, we will discuss routinely measured vital signs in the NICU and discuss normal and abnormal values. We routinely measure axillary temperatures in the NICU. The normal axillary temperature range is 36.5 to 37 degrees Celsius. Either hypothermia or hyperthermia can be caused by several things. Environmental factors are perhaps the most common reasons, such as a temperature probe or isolate malfunction, infant swaddled or layered too much or too little. Prematurity is also a factor. Infants may be unable to maintain body temperature due to decreased brown and white fat, immature hypothalamic function, and their large surface area to weight ratio. Sepsis can also be responsible for variations in temperature and should always be considered as a cause. The normal range for neonatal heart rate is 80 to 160 beats per minute. The rate is lower during sleep and higher when crying or agitated. Gestational age can play a factor in heart rate as well. The older the infant, the lower the resting heart rate may be. Bradycardia is defined as a heart rate less than 80 beats per minute for term infants or less than 100 beats per minute for preterm infants. Bradycardia can be caused by vagal stimulation during stooling, vomiting, feeds, or reflux, and or suctioning. Other causes include sepsis, hypothermia, acidosis, hypoxemia, airway obstruction, pneumothorax, or apnea. Tachycardia is defined as a heart rate of over 180 beats per minute. There are several causes of tachycardia, including anemia, hypoxemia, sepsis, shock, hyperthermia, pain, agitation, and medications, including caffeine, or arrhythmias. The normal range for neonatal respiratory rate is 30 to 60 breaths per minute. Tachypnea is defined as a respiratory rate above 60 breaths per minute. Some common causes include pulmonary, cardiovascular, or metabolic diseases. It may be unsafe to orally feed an infant with an increased respiratory rate due to the increased risk of aspiration. Apnea is defined as the absence of breathing for more than 20 seconds, or for a shorter period of time when associated with oxygen desaturation or bradycardia. There are multiple causes of apnea, including apnea of prematurity, but other causes include CNS injury, sepsis, or metabolic abnormalities such as hypoglycemia, hypocalcemia, or hypermagnesemia. Anemia can also be associated with apnea. The diagnosis of apnea of prematurity should be made after other causes have been considered and ruled out. Apnea and bradycardia events are documented in a flow sheet by the nursing staff and can be reviewed in the AB Spells report found under the Report Index section of a patient's summary. It is important to note the degree of bradycardia and hypoxia associated with the event, as well as what the infant was doing when the event occurred and what type of intervention was required to stop the event. The event can also be reviewed on the infant's bedside monitor. This data can help to differentiate between types of apnea such as central, obstructive, or mixed apnea and guide diagnostic evaluation or management decisions. Several examples include a 30-week gestational age infant not previously on caffeine therapy having AB spells with no chest wall movement occurring during sleep that requires vigorous stimulation to resolve may benefit from caffeine therapy for treatment of apnea of prematurity. Another example, an X28-week gestational age infant that is now corrected to 32 weeks on CPAP and caffeine continues to have intermittent AB spells with mixed chest wall movement that requires mild stimulation for resolution, may benefit from continuing CPAP for an additional period of time to help prevent worsening of mixed or obstructive apnea. Neonatal blood pressure is affected by gestational age, birth weight, and day of life. One common approach to define hypotension is to compare the mean arterial pressure with the gestational age of the infant in order to determine the minimal mean arterial pressure to accept. For example, if a newly delivered infant is 28 weeks gestation, then it may be acceptable to have a mean arterial pressure as low as 28. However, it is important to consider clinical signs of perfusion to determine if the blood pressure is adequate to meet tissue demands. Prolonged capillary refill and poor urine output may indicate hypotension. Hypertension is defined as blood pressures consistently above the 95th percentile for age. Ensure that the blood pressure is obtained with an appropriate sized cuff on the right upper extremity while the infant is quiet. In general, we start to look at hypertension when systolic blood pressures approach 90 to 100 millimeters of mercury. It is important to confirm the elevated blood pressure. Current ranges for normal blood pressures can be found in resources such as the Harriet Lane Handbook. Pulse oximetry measures the relative absorption of light by saturated and unsaturated hemoglobin. Oxygen saturation goals can be different for each patient, and it's important to know these goals. In general, for premature infants with lung disease, an acceptable oxygen saturation would range from 88 to 93%. For full-term infants, acceptable oxygen saturations are above 90%. There are risks when saturations fall outside of the acceptable ranges. If the oxygen saturations are too low and the infant is hypoxic, then end organ damage can occur. If the oxygen saturations remain too high, oxygen toxicity may result in conditions such as retinopathy of prematurity. Infants with congenital heart disease may have different oxygen saturation goals depending on their specific cardiac lesions. For example, in complete mixing lesions, such as an AV canal, oxygen saturations between 75 and 85% may be acceptable.